Hello, this is Social Work 637 in the winter semester of 2021, and we're in week 6 where we're talking about the integrated health workforce. So today we have a panel of individuals working at various types of settings that use workforce and team members, including social work, but also including peer support specialists, peer recovery coaches, and community health workers. And so our panelists today will talk a little bit about these really important team members and some of the policies related to our work in the field of integrated health. I am Carrie Rheingans. I'm one of the 10 instructors for Social Work 637 this semester. I work at the Michigan Department of Health and Human Services, and I oversee a statewide project around substance use disorder services. Through that work, I've gotten to know Pam, who's one of our panelists, and I previously worked with other folks on the panel. So I will call on each of you panelists to please introduce yourself. I'm going to go in alphabetical order by last name. So let's go with Lisa Jackinchuk. Can you please introduce yourself and where you work and what is your role there?
Sure. Hi, and thank you for having me today. As Carrie introduced, I'm Lisa Jackinchuk. I do have an educational background as a master's in social work with a clinical focus. I graduated from MSU probably about 20 years ago now. And so I've been working in the field in a number of capacities. Currently, I am at the Michigan Center for Rural Health, and I am a project director on a specific project under the center, which is the Northern Michigan Opioid Response Consortium. So we're focused in the Lower Peninsula, Northern Michigan, in 18 counties right now, and our work is focused on SUD. We do have a large component of that work that's focused on recovery. And that's where I have really been exposed to a lot of work with the peer supports. So in regards to recovery coaches, working in the realm of SUD or substance use disorder, sorry. Prior to this work, I was at a rural health clinic in Eaton Rapids, so just south of the Lansing area, and worked within the RHC as a director and helped in integrating our behavioral health services into that practice. So that was primarily working toward an integrated health model with social workers, working side by side with the physicians and nurse practitioners.
Thank you very much. Next, let's have Janelle Murray introduce yourself, please, and tell us where you work and what your role is there.
Hi, yes, I'm Janelle Murray. I currently work at Michigan Primary Care Association. I am the Associate Director of Integrated Health. So my current role focuses on any substance use disorder services that health centers are providing, along with behavioral health integration and just any integrated health, really looking at their program that they have and program development and helping them do some implementation at any of the health centers in Michigan. My background includes a lot of substance use disorder. So I've been about 9 years in the substance use disorder field. I've been a program director for a health department and then also for a nonprofit, both with substance use disorders. I am not a social worker. I have my bachelor's in dietetics and then my master's in public health. And I somehow just landed at the at substance use disorder. But I have had oversight of social workers and clinicians for the programs that I ran. I do a lot of trainings throughout Michigan. So I'm a adverse childhood experience master trainer for the state of Michigan. I've done naloxone and Narcan trainings. So that's the opioid reversal medication. And then also do a lot of trauma-informed care.
Thank you. Great. Next on our list is Celeste Sanchez Lloyd. Please introduce yourself and tell us where you work and what your role is there.
Yeah, so good afternoon, everyone. I'm Celeste Sanchez Lloyd. I am currently the program manager for Strong Beginnings Healthy Start. We're a federally funded program in Kent County. Specifically, I live in Grand Rapids, Michigan. So For Kent County, what we're focused on is reducing disparities in preterm births and infant mortality amongst the African American and Latinx population here in Kent County. We're a home visiting program. We have about 27 community health workers. We're in partnership with the Maternal Infant Health Program. You may have also known it by MIHP, which is a Medicaid funded program through the state of Michigan. And so in collaboration with MIHP, our CHWs go out, they visit moms and their families. We have a fatherhood component too, that goes from pregnancy to 18 months after delivery. And so it's focused, we rely completely on our community health workers. But how I got to that area, so I'm very passionate about community. I have a BS in Child Development and Family Science from Purdue. I have a MA from Western in the same field. And so I love community. I love looking at how we can reduce disparities amongst vulnerable community, along with looking at those social determinants of health. Looking at how race plays a part in this, especially in the United States, and how we break systemic racism when we're looking at diverse and vulnerable communities. So that kind of has taken me to this road. I'm part of a lot of different initiatives around supporting the work of community health workers, both at a local, state, and national level. I'm currently the vice president for MISHWA, which is the Michigan Community Health Worker Alliance here in the state. Also sit on a CDC working group for community health workers. I'm also part of an advisory group for the CHWs at the federal level. And so a lot of work around how do we integrate community health workers and the healthcare team, making patient-centered care and making sure that we're really reaching all the needs that we have when we're looking at patient interaction, either within the healthcare system or through your local community-based organizations. And so that's some of my work. So I'm happy to be here with you guys today and kind of share a little bit of my experience.
And it's really nice to have someone from the western side of the state. I think we get a lot of speakers from the southeast and sometimes from Lansing area. So thank you for joining us today. Pam, can you introduce yourself and say where you work and what your role is there? And I see our fifth panelist has joined, so I'll be adding her to the panel here. And go ahead and unmute yourself, Pam.
That's my joke on Zoom anyway. I should have a sign, mute and unmute. So I'm Pam Werner. I work for the Michigan Department of Health and Human Services in the behavioral health area. And I work in the Office of Recovery-Oriented Systems of Care, and I lead up the Peer Specialist and Recovery Coach Initiative. I developed a warm line this year, and I have my master's in clinical psychology from Western Michigan University and bachelor's in occupational therapy. And I have worked with social workers for years. So glad to be here.
Thank you, Pam. And Algeria, welcome. You came in perfect timing. It's your turn to introduce yourself. We're saying where we work and what your role is there.
Perfect. I will also say, Pam, we've heard amazing things about the warm line. So it's good to meet you. I'm Algeria Wilson. I'm the Director of Public Policy with the National Association of Social Workers, Michigan. And I'm happy to be here. We'll talk a little bit more about what I'm doing here, I suppose.
Well, actually, let's start there. Not to put you on the spot as our newest joining panelist, but, you know, all of the people attending, well, for the most part, most of the people attending class this afternoon or watching the video will be social work students and future social workers. We do have a few students from other schools, but, you know, can you tell us, Algeria, a little bit about what the role of public policy is at the National Association of Social Workers here in Michigan?
Yeah, I see we have one of our board members on here. Hi. So NASW, we advocate not only on behalf of social workers, but on behalf of anywhere where a social worker may be in the clients that they work with. So as you may know, the social work profession is very broad. But one of the common elements that we know exists, right, is mental health and substance use disorder. So right now, NASW is heavily focused on behavioral health, which is substance use disorder and mental health, and physical health as well. And so one of our areas that, you know, is our prime focus right now is co-response, crisis stabilization, and behavioral health workforce expansion. So co-response is, so I'll just, sorry, NASW is the National Association of Social Workers, Michigan. So I just want to make sure everyone knows that. But the co-response model within public policy is very critical. Right now, we see that there was momentum around the jail and pretrial task force with an effort to really do some criminal justice reform and put money where money needs to go. And so co-response would be, social workers, clinicians responding with police, but particularly outside of the police department, providing, some crisis stabilization once they do have that response. But then also we need a strong workforce that can do that. So NASW is very focused on expanding that workforce so that we can do all of those elements.
Thank you. So thinking about the different types of workforce members we have here, this panel is not, we don't have a physician, we don't have a physician assistant, we don't have a nurse practitioner, we don't have some of the care team members that are, long defined, long certified, licensed, and paid for, because those professions and those members of care teams for integrated care have been, like I said, long defined, and they have been paid for by health insurance for, years and years. So I wanted to make sure that this panel highlighted some of the workforce that is, in my opinion, more innovative. So community health workers are still trying to get, a state recognized licensure or certification here in Michigan. So Celeste, can you talk to us a little bit about what that might mean to community health workers as a workforce, as far as that kind of policy to be certified or otherwise recognized by the state of Michigan?
Yeah, I think whenever we think of licensures, or we think of how can we have credentialed, individuals. Somebody's not on mute.
And I don't have it in my phone. You need it today? I can go.
Sorry, folks. I'm going to try to mute.
I'll probably have to Google
Try to mute the background noise. Okay, thank you.
No problem. So yeah, so when we talk about, how do we make CHW sustainable? I think there's been a long concern in the past on what's the return of investment for CHWs? How do you make sure that CHWs are working to their full potential? How do they benefit? And I think time and time again, we've seen that when you take intricate community members who belong to their community, they have a trusting relationship with community, and they work in partnership with social workers, with physicians, with, behavioral health, that there is a return of investment. They're going to tap into, situations that maybe we didn't see in the visit or in the clinic or in the office site. And so one thing that we've been working really hard on, to Carrie's point, is how do we have CHWs reimbursed through Medicaid? And that comes with some benefit, and it also comes with some hindrance, right? Michigan still has one of the lowest rates of reimbursement through Medicaid, which is difficult. And when we're talking about workforce development, you want to make sure that individuals are paid at a livable wage and not the minimum wage. We want to make sure that they're able to provide services to their community members and not have to enroll in those same programs due to funding and how they're being paid out. And so MISHWA has been working really hard behind the scenes in partnership with MDHHS, making sure that we are not just including CHWs in budgets and reimbursement rates, but how do we make sure hold the accountability to organizations such as, healthcare plans? How do we increase healthcare plans awareness around community health workers? So we've done a lot of conversations both at the state, local level with healthcare providers, making sure that they're including community health workers in their offices. Insurance providers, how do you budget? We're happy to say, I'm housed within Spectrum Health, which is in collaboration with Priority Health, and they've within the last 5 years have increased their staffing to include community health workers. We're seeing HAP include those, Molina, along with Blue Cross Blue Shield. So their health insurance companies are coming on board that they can provide better services to their members when they include community health workers. And so we're really trying to change this frame of thought too, of reimbursing CHWs and more financing CHWs. How do you make sure that you're including them in your budgets? How do you make sure that you allow space for your social workers and your physicians and your PAs to work at the highest level of their licensing by having a CHW on staff, so that the CHW can do some of those more intricate, maybe connections to resources and referrals. And so we see that cost benefit there. We also see that the collaboration between the teams are stronger. And so when you start having stronger teams that are providing services, then you start seeing that you're not spending money on maybe unnecessaries, right? An overworked social worker, an overworked staff member that's now leading to burnout, short-term disability, because they can share the workload. So we're doing a lot of those return of investments behind the scenes to make sure that individuals understand the importance of community health workers.
Thank
I
you so much. Yes, I was going to ask if you wanted to add, Janelle.
Well, Michigan Primary Care Association is working with some of the insurance companies. I believe it's Molina and then United Healthcare that are having an initiative to have community health workers in the federally qualified health centers. They are paying for them, and we are doing monitoring and education for them, and then also going to have reports for the insurance companies so we can show them the return on investment for it. So a lot of times what Michigan Primary Care Association does is bring these new innovative models to the health centers to see return on investments. So they get funding for that.
Thank you. Lisa, do you work closely with community health workers in any of the rural health centers that you know of?
So yes, in Northern Michigan, the FQHC, so the federally qualified health centers, are beginning to employ the community health workers. We had one center that had a peer support specialist that they had hired, and we were able to work with them to get her to go through the training for the community health worker. So we have been doing a lot of promotion of the community health worker and trying to get through a partnership with one of the methadone clinics that we work closely with that also provides, it's a different model for the recovery coach training than the state-based. It is the CCAR, so the Connecticut-based training, trying to work with many of those coaches that are coming out of that training model to then potentially pursue their community health worker certification. I feel as if there may be a lack of education potentially in regards to the benefit, because we even have some funding available to help pay for individuals to go through that certification. And at times we've had a hard time filling some of those slots and opportunities to have individuals pursue that.
So, oh, please go, Janelle.
Sorry, I'm like, I have something to say about all of it, but I'm currently working with the state for the opioid health homes and the behavioral health homes to host a community health worker training. Also part of a grant that I got through the state and CDC, we're going to be offering some community health worker training for peer support employees, because we think that that's going to be something that's going to be more eligible to be reimbursed than just peer support specialists at FQHCs, federally qualified health centers.
So thank you for mentioning that, Janelle. And Lisa, you mentioned it too. You talked a little bit about this kind of cross training. And so Pam, this is a good segue to ask you to explain a little bit, what are the types of peer services that you oversee at the state of Michigan government? And then how are those financed or funded?
Sure, we have a large array of peer providers with the state. So for persons with developmental and intellectual disabilities, there's peer mentors, and we have youth peer support specialists and parent support partners and consumer run drop-ins. And then I lead up the Certified Peer Support Specialist Initiative, which are individuals in a lived journey of mental health recovery. And then we have a peer provider who's certified as peer recovery coaches. And some of those individuals that are co-occurring would have dual certification. So they are Medicaid providers. They have been since 2006, although our peer recovery coach certification became formalized in 2018. Used to be a CCAR training like Lisa talked about, but because CCAR trains people without lived experience, so they're not necessarily peers, the state, in support with SAMHSA, Substance Abuse and Mental Health Services Administration, developed a curriculum with us for state certification of peers. And peers have done health and wellness roles forever. Since 2006, peer providers have had integrated health within their Medicaid provider description, so they can get Medicaid reimbursement, Healthy Michigan, by doing any health and wellness activity that's, related to even self-management goals, integrated health. But what we found is that we really wanted to give more in the way of physical health. So a couple of years ago, we started working with MISHWA, the Michigan Community Health Worker Alliance, that Celeste has already talked about. And we have certified 68 peer support specialists and peer recovery coaches as community health workers. And in general, those roles are community health workers, but they're not a certified role. So through that partnership, we're working this year with having a couple peers become trainers so that we would have a peer-to-peer educational setup. And so 68 peers as community health workers. We have over 2,050 mental health certified peer support specialists the state is certified. And we have over 850 certified peer recovery coaches who work in a variety of roles. So I did write a grant a few years ago. So we have peers and recovery coaches that work inside the prison that are incarcerated and had to be incarcerated. So they are individuals that, will someday be returning citizens. Although when we did that training, we did ask for people to be doing life without parole for, unfortunately, the sustainability of the project. And we have amazing outcomes that are happening within the 6 prisons that we've trained, and all the individuals get the same certification. We have 140 people incarcerated that are trained as either or both mental health and certified peers. Other things that peers do, as community health workers, these are evidence-based professions. So they're not just like groovy cool. They need to be integrated in the whole treatment plan. And so really, if people do not have a community health worker in a peer, in an integrated health environment, they're not doing justice to the population they serve, and they're not helping people with wellness goals, because the view of peer specialists really comes from what were my chronic conditions that I had. And we know that psychiatric medication has caused morbidity and mortality, where people with mental health conditions die 25 years earlier than the general population. So who better than somebody who's had diabetes and has a mental health condition or a substance use issue to help run chronic disease self-management classes. We had a grant where we had peers in 2 federally qualified health centers. One was in Muskegon, one in Holton Lake. And it was amazing return on investment, all the great things that they brought to the table. But what they didn't bring to the table was money. And as you get into asking barriers, you can't do soft funding with a grant and expect sustainability to happen if there isn't funding that exists afterwards. And then just some of the other areas that peers work in addition to do evidence-based wellness recovery action planning, re-entry. They work on assertive community treatment teams. They work in substance use residential. They work in medication-assisted treatment programs, and we will be training peers that are just doing that incarcerated in the prisons about the role of peer recovery coaches. They work in courts, mental health drug treatment courts, human trafficking courts. They do health coaching, and many of the Medicaid health plans have hired peer specialists. So that's my quick overview.
That's a lot. It's a lot because these are important fields. And like you said, Pam, these are evidence-based services that are being provided by people who have experience with the conditions that their patients that they serve are also experiencing. So that adds a little bit more of a connection than possibly the other providers on the integrated care team, even the social workers. I did add to the chat box some links about peer services in the state of Michigan and added the link to the Michigan Community Health Worker Alliance. I'll add these to the page when the video is uploaded so people can learn more about what's going on here in Michigan. And I know you mentioned there's some cross training with the peer support specialists, peer recovery coaches, and community health workers here in Michigan, in part because our state government Medicaid program does not yet pay for community health workers as a specific service. And I want to explain a little bit about how that works, how a service or a profession can be paid for in Medicaid. And Pam, you can help me correct anything I get wrong, okay? So in order for our state government to be able to pay for the services of a certain kind of provider, we need to have some sort of assurance that that provider is competent in their field and has high training and is high quality. And, so we need to find some way to quantify and ensure that as our oversight as the government, right? And so for many professions, the people in that profession, they determine what it means to be competent. So the National Association of Social Workers can help determine what it means to be a competent social worker. It's the same for other kinds of professions. And those professions can then determine what it means to be licensed. And then state governments can adopt those licensure guidelines and then make the requirements for the different professions to become licensed, certified, et cetera, whatever level it is. Licensing is a little bit higher level than a certification. And when we make contracts with health plans or prepaid inpatient health plans to have them then pay for the services of certain providers, they want to make sure that they're paying providers who have been adequately trained and are, at a certain level of competency to serve for the particular services that are needed. And so currently in Michigan, what Pam was just explaining is that the state has created these certifications with criteria about lived experience with the health conditions. And now some of those dollars can be used to pay for those services. It may not be exactly fee for service in every case, meaning that a peer support specialist talks for 15 minutes to somebody and then can bill for that 15 minutes of time. It's not necessarily like that. The way that the contracts work for those peer support and peer recovery coach contracts. It is not the same with community health workers. Right now, we do not have some sort of code in state of Michigan government certification for community health workers. Community health workers are paid for with specific contracts with health plans or with grant funding. So those are not necessarily sustainable and ways for CHW employers to be able to plan for the long term. So please add some information here, Celeste.
No, you're spot on, right, Carrie, about the idea of how do we fund community health workers with kind of all these hoops we have to jump through. Fortunate for Strong Beginnings, the program which I manage, we've been working with the state closely since 2016 around a PFS, and PFS is it's a pay for success kind of bond. It's a social bond system where every Medicaid dollar we can show the state that we're reducing, they'll reimburse it back into our program through a mediator and such forth. But it's another way of how we have to be strategic and kind of innovative on showing the state exactly what Carrie's mentioning is how do we make sure that individuals understand the importance and the level of expertise that community health workers bring to the table. And so a lot of the talk this afternoon has been about funding, and it's because when you think of community health workers, almost 90% of it is grant funded. And as you know, with grant funding, you have to either reapply or those funds are gone. And so when we're talking about who's using community health workers, it tends to be the most vulnerable communities. And if you have a program pop up this year and because loss of funding, they're gone tomorrow, imagine, what kind of relationship that ties into the communities that they're serving. And so that's why finance is such a big part of this conversation, is how do we make sure to keep that sustainable for the communities we serve? And we've just been able to really show forth that when we have community health workers, you're hearing the conversation over and over again, that, and we can elevate them to the healthcare team, they really do reduce, costs, and they're able to be an enhancement to the healthcare team overall.
So we do have some questions about, reimbursement and how come these are professions that are paid so little. Before we get to that question, I want to talk a little bit about licensing and social work. And, like I was mentioning earlier, the state wants to ensure that a professional is meeting some competence and training level before their services are reimbursed. And, here in Michigan, we do have a licensing for social workers, for both interpersonal clinical social workers as well as macro social workers. And, you can look online, and NASW can help you figure all those criteria out. But the state of Michigan's Medicaid program does actually credential, the health plans credential social workers, and those services can be paid for. There are a lot of social workers who don't engage with the Medicaid program in Michigan, and therefore they might contract or get credentialed or paneled by just a private health insurance company, because those health insurance companies maybe can pay a little bit more than the rate that Medicaid can pay. And so going back to this question about reimbursement rates, Celeste, I know you do some work nationally, and you said Michigan's one of the lower rates of payment for CHWs. And Pam, I don't know if you want to have any comments on this about peers, but I'm curious why either of you think these are low reimbursed, and maybe Algeria or others might be able to comment about the low reimbursement rate for social workers as well.
Yeah, I'd like to just address the reimbursement rate. So in the way of Medicaid, the money comes from the federal government, and then it comes to the state. Then it goes to these 10 managed care plans on mental health side. And then they send it down to 46 different counties. So layer, 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 layer. So you have all these layers of administrative costs that are coming down through there. Then what happens is some states will say, this is what you're going to pay a community health worker. This is what you're going to pay a peer. We're going to break it down into 15-minute increments. In Michigan, all of these counties and all of these providers can pick what rate they pay per peer, per community health worker on the mental health side. So in Detroit, we did a study, and they pay the lowest wages for peer specialists, minimum wage, non-living wages for the most part. But you can go to Genesee County or Muskegon, and they make at least $7 more an hour. Now, why would that be when that same money's coming down? Because by the time that money hits a community mental health program, they're looking at how they spent it before. They're looking at the population, how many people they have in jail, how many people with developmental disabilities, and they do some different formulas. So then it becomes real confusing on how much money is going to administration and how much is going to a peer provider.
Yeah, and I can talk a little bit about social workers, because there's also a challenge with our reimbursement rate. So, social work has been professionalized for quite some time, which means that, if you want to be a clinician, then therefore you need to sit for an exam from the Association of Social Work Boards, pass that exam, work in your field, get your hours, and receive a certain level of supervision. But in order to pass that ASWB exam, you have to have taken, a certain amount of courses. And get those knowledge, skills, and abilities, like the courses that you're in now. And that's determined by the Council on Social Work Education. But again, on that state level, within LARA, which is a Licensing and Regulatory Affairs Agency, we have the Social Work Board. And they work together to draft our rules to say how many hours of supervision you should have, how many hours of work you should have in the field. If you work in a clinical setting, once you take your exam, you'll be a clinical social worker. If you're in the macro space and you want to take your exam, you'll be a macro social worker. But those rules turn into statute. So whatever work you're going to do, it has to be within that statute. So as a clinical social worker, if you're out, doing work, the insurance panels can say, based on the definition within this profession, you will be reimbursed as X, Y, and Z. So we see psychiatrists reimbursed at 95 cents an hour, I believe. And there was a point where social work was reimbursed at 55 cents, I believe. And when I first came into my role a few years ago, there was this discrepancy with Medicaid where social workers, for some reason, were being reimbursed for 75 cents an hour. We verified, MDHHS said, yeah, great, this is how it's supposed to be. We've had this increase. Well, a few months later or a year later, they dropped it back down to 55 cents, and they asked for recoupment back from social workers. So you need to pay this money back because we made this error. And so we had to do a lot of advocacy for social workers to be able to get those funds back. But yes, it is, especially across health plans, Medicaid included, very low reimbursement rates. That's where you hear, the need and the push for advocacy for higher increased wages. Sometimes this is why we see social workers only accept private pay, especially from, if you have your own private practice, you are a business owner. So there are various different barriers to service for those who are in need of mental health, behavioral, or mental health and substance use disorder. And maybe, I don't know, Carrie, if you can talk about that split in the funding between substance use disorder services and mental health services as it relates to payment structures. But there are many barriers that you all should be aware of as you prepare to go into that field and try and find ways to reduce those barriers for your clients.
Sure. So I think in week 3, the class talked about financing of health and healthcare services. And we talked a little bit about how public funding works here in Michigan, and that in the Medicaid system, like Pam said, the feds give us some money, our state government adds some money, and then we have this big pot of money for our healthcare services that we pay for in Medicaid. Well, we carve a chunk of that out into our public behavioral health system. It's a small chunk compared to the overall pie. So this small chunk then gets distributed into 10 regions, like Pam mentioned. Some of those regions have even further distribution among specifically community mental health providers. Those community mental health agencies, they pay for the services serving people with severe mental illness, severe emotional disturbance for youth, and for intellectual and developmental disabilities. So those 46 different geographies make contracts with service providers to cover those services. And then on the substance use disorder side, those funds are administered directly by the prepaid inpatient health plan. There's 10 of those in non-overlapping geographies in our state. And they also have another funding stream of some block grant funding that's used for other substance use disorder related services. And so there's kind of these 2 funding streams that can pay for substance use disorder treatment, recovery, and prevention services, as well as recovery services for substance use disorder. So it is a little bit confusing as a practitioner trying to figure out, okay, if I spend this amount of time doing substance use disorder services, but this amount of time doing mental health services, I have to bill 2 different things, and then if you happen to be a social worker who can help with not only those behavioral health issues, but also some physical health coordination and management, then you bill yet another area. So this all plays out at rural health centers and other and federally qualified health centers and other health centers. I don't know, Janelle and Lisa, if you want to talk a little bit about the complexities of trying to figure out how to fund the work of this interdisciplinary care team.
That's my issues every day. So I actually did just get in contact with the health center, and they were just wondering even how to start certain services and what rules there are. Do I need a license for this? Because we have behavioral health services, but we want to start SUD services, substance use disorder services. There's so many different rules and regulations, especially with the split of having the money going to the prepaid inpatient health centers or inpatient health versus the mental health. So it's very confusing. So that's something that we help guide with them, but they also aren't understanding or think it could be too confusing to start a lot of this. So a lot of we're trying to get integrated care to really work at these federally qualified health centers, but it's a lot of coaxing them that yes, you will make money if we can get the billing codes right for you and see what you guys can do, and understanding what the full-time employees will look like too.
So Lisa, I don't know if you want to make any comments about the
Just
joy of.
agree, yeah, with everything that's been said. It is challenging. At the rural health clinics, though, we did have a successful model in place at the specific clinic I was at in regards to being able to bill once the clinical social worker was on the differing insurance panels, and then not billing specifically for straight Medicaid, but with like the McLaren Medicaid and PHP-CAID, so the differing products. So there are opportunities. What's that?
What is
Physician health plan Medicaid?
Okay, thank you.
Yep, sorry. And so just looking at the options and opportunities and the billing models that exist, and working with like Janelle to.
So I guess, one of the questions was, why does Michigan have lower amount of money to pay these professionals, right? The professional community health workers and peers and social workers. Well, part of it is because of this multi-leveled administrative structure that we have. But it's also a little bit in part of us using managed care in our system. When we have managed care, we use a little bit of a different kind of calculation. And we think of, the way we budget is we think of the amount of money we have for the course of the year and try to fit all of the services into that, as opposed to everything being completely fee for service. And with Medicaid, our state being able to just kind of bill until, the feds won't tell us no, they'll always match our whatever we bill, but we don't have that arrangement with the feds for Medicaid. So it's a little bit different with private health insurance. So at the health centers in our state, there are plenty of people who go there that have private health coverage. And those are another kind of contract that you have to get as a type of provider or as a type of setting, that you have to make a contract with those private pay health insurance companies. And so that's like another type of administration that has to be figured out. So trying to do the calculus of how do you bring in enough money to pay for all of these services is very complicated, and is actually the kind of policy that social workers can influence. So the students in this class, you're all taking this class around integrated health policy. And social workers have this great viewpoint of considering social justice, considering adverse impacts of policy decisions. And so as a setting like a health center, or even a very small primary care site that isn't necessarily a health center with many services, as they're trying to figure out how to ensure the services for their patient population, having social workers provide input is very important into those policy decisions. And it's very important for social workers to do advocacy, not only for our own profession, but for these professions that we know really benefit patients, community health workers, and peer services. So one question we got, Pam, was for you about the payment of peers in the carceral settings. Are they actually people who are incarcerated that get paid to do those services?
Yes, and it was the women at Women's Huron Valley who advocated this, and they did not give up. So it is the highest paid wage for people incarcerated, which is $3.30 a day. And before, the role of the peer was as $1.10. But
wow.
There's one other position in the prisons, and it's called the suicide observation aide. And so now the peer role is paid slightly more than that one. And it's exciting. And the Department of Corrections has taken over the whole program and figured out funding. And we've been able to fund another project through harm reduction in the prison. So that's exciting. And I guess just to back up what Carrie was saying, is when people say the system is broken, I don't know how many of you have heard the system is broken, the system is broken. It's not broken, it's underfunded.
It has been for
Michigan was one
decades.
of the last states to get parity. And many people who are maybe on here now, when you look at the amount of people who've struggled with a mental health or substance use condition, if it's not in your life, it's in a neighbor's life. So many of us with family members, but it's really hard, I think, for people to come out and advocate for themselves and go to a representative's office. But they just showed a report that mental health in our central office has way more employees than our public health and our Medicaid offices. And some people use the word stigma. I personally don't like that word because it really needs to be called out for what it is. It's prejudice and discrimination. We don't use stigma if you have breast cancer or physical health issues. They only use that word for mental health anyway, but really, I believe that substance use and mental health populations, there's prejudice and discrimination, and I hope all of you go out there and make a difference on your advocacy with it.
I'll say that at the health centers, that's something that we do see is that physical health has been more important than mental health. And some centers are not understanding how mental health and physical health combine. And that's, you know, every center is different. So it's very interesting to see the different levels of knowledge in trying to get them to understand just how important mental health is as physical health. And so there's a lot, I think, of work still to be done with integrated care because people do need to understand the importance of it. In MPCA, we have an actual employee that goes and does work at the Capitol and does advocacy and does things around any of the policies that are being created through the state. So that's something that we provide too. So we are actually coming right from the voices of the health centers to let them know what the health centers are experiencing and what's needing to be done.
And Celeste, I saw you had your hand up for a second.
No, I was just going to add to Pam's earlier comment that not only is it underfunded, but it's not broken. It's doing exactly what it was intended to do. And when we think about vulnerable communities and communities primarily of color, Black and Brown, and Indigenous communities, those systems have been in place to continue to hold those families in the situation that they find themselves due to systemic racism, due to, you know, historical context that, you know, and we see that among rural poverty-stricken families too. Those systems don't work. And so I think to the conversation earlier, which is how do you use your expertise as social workers? How do you use your expertise as community health workers? That civic responsibility, it's not just providing health services to clients, but it's also how do you voice, how do you make sure that you're meeting those policy changes, meeting with those open forums, and as an organization or as a network, how do you continue to advocate for the community members that are coming through your doors, right? Because we can provide all the great services we want to, but if we're still applying Band-Aid approaches to real surgery issues, we're not going to get to where we need to be. Our communities will continue to see the same fragmented services over and over again. And so I think we have to lend our voice and lean into that uncomfortable situation of saying, we need we're requiring higher pay. We need additional resources. I can't watch the chat because it distracts me. But even someone said, wow, $3 sounds horrible, you know, when we think about it. And it's true, $3 is it great compared to the dollar? Of course it is, but it just shows us also where we still have room and we have gaps and areas to be concerned about. And I think, you know, that's where we're saying, where can you lean in with your expertise, with your community advocacy? That is part of helping and really creating a healthier community. You have to lean in that civic duty.
I saw your hand up, Algeria.
Yeah, no, I was just going to add, as we were talking about low reimbursement rates, and hey, when the pandemic happened, we saw this huge shift in mental health providers being able to offer telehealth services, which was really a great opportunity, right, to be able to have a broader reach. But what we saw and what we continue to see is reimbursement rates are lower for those who are doing telehealth services versus those who are providing services face to face. So that's problematic. And it's not only just for the social work profession, it's for various different professions. We see this with speech language pathologists, with physical therapists. There is a huge issue with reimbursement rates. We worked with some of those interdisciplinary professionals to introduce legislation to be able to raise those reimbursement rates. But insurance companies, they don't like to be told what to do. They don't want to be mandated to pay out a higher rate. I believe this bill is actually going to be up. Oh, may have been up today. Oh no, the 24th. I believe it'll be getting reintroduced by Senator Ollier down in Detroit. So as we talk about advocacy, what can you do? You need to be a part of NASW, right? To utilize your voice. That's why I love macro social work, because we can work with individuals every single day, which is great, but you're going to run into so many barriers sometimes that, will prevent you from being able to do your best work. And as micro clinicians, there's still room for advocacy. You have that duty to your client to be able to advocate on behalf of their needs. So you really should be doing both, but really starting to figure out where those structural barriers is amazing. And to be able to be a part of that process and changing that process for those who you work on behalf of.
Well, thank you. So normally I would end the panel by asking what all the panelists think social workers can do. And I think what you all just commented was that social workers, regardless of whether you're interpersonal practice clinical social worker or a more meso level or macro level, can use your skills to advocate for your profession and the really important sister professions of peer services and community health workers. Social workers, we know that authentic relationships and relationship building with our people that we serve is very important. And, between social workers, peers, and community health workers, we really use those skills and have the time. And it's part of our duty to use those skills to build relationships and really engage our people that we serve. Any final comments? We're coming up on an hour, and I'm just wondering, from the rural health perspective or health center perspective or any of the professional focus areas, what final comments do you have to students in the field of social work learning about integrated health?
The only thing I would say really quickly, and I definitely want to pass it over to other panelists, is, I think it's very important to know that social workers can't do it alone, not even just on an individual level, but even when it comes to working with other professions. Sometimes we stay too siloed in our profession and we're not working in this integrated space as much as we should. As you go along, working in this integrated behavioral health setting, you may be the only social worker. But it's very important to not only stand up for the profession, but work in a manner that, again, is best on behalf of your community. So I'll just move forward. I'll drop my email in the chat if you want to know more about NASW.
And I agree with Allegra on that. I definitely think that, again, all health centers aren't really at the top of integrated care as they could be. And it's kind of a leadership of the physician, the nurse practitioner, and then the social worker is underneath that. But you need to be on the same level as them, and you need to advocate for yourself as that. You are just as important to the patient as they are, and they need to understand that, and you need to show that. So be confident and go out there and get them.
And just to piggyback off of that, in that process of showing the value as the social worker within an integrated team, many times the physicians, the nurse practitioners, physician assistants may not know exactly how you can impact the care of their patient. So being certain to really provide that education to the team as a whole. I think many times the thought is, social workers maybe doing linkages to resources or maybe social services, and they don't understand all that a social worker can bring to the table and how a social worker can impact behavior change to improve somebody's diabetic management. And so really helping to make those connections, because many times physicians and nurse practitioners and physician assistants see something as a medical aspect, and that it needs to be treated with a medicine or treated by that medical provider. So just being certain to educate and show how you can positively impact the situation as well.
Thank you.
Yeah, I
Celeste?
think Algeria hit it right on the head too for me around not working in silos. A lot of the conversation I have with social workers and MAs is really about how can you work to the highest level of your license? And that is by working in collaboration with other professionals, community health workers being one. Getting out into the field, getting out into your local communities, your neighborhoods you're gonna serve, know who are there, know who are the community champions, because more than likely those same individuals that live in that community are the community members you're gonna be servicing. And so it goes beyond, you know, I've heard social work students say, well, Celeste, I've done a community rotation. That's great, but your 2 weeks can't equate to, you know, the long-term effects that some of these communities have dealt with. And so getting out there, understanding, working with some of those champions really allows you to work best at your highest level. And so I would, you know, definitely echo what's been said already. I think these are some great key points.
Yeah, and I'd just like to follow that out to make sure that you keep your eye on the prize, and that's the person who we exist for. That's who really indirectly or directly is paying your salary, and to involve that individual in person-centered planning and figuring out what their perspective is. Because many times things are given to that person that they didn't want to begin with, and lots of things are rolled into that case that they may not have needed, and to really look at what that person's voice is and what the family's voice is, and when you're advocating, including them, because a legislator is going to listen to somebody who's experienced some of the lack of integration. So that is one of my big platforms. So thanks.
Well, thank you. And we are coming up on an hour, so thank you all panelists for joining today. I think, you know, today's topic was the workforce and integrated health, and I think social workers saw a little bit more about how we fit into a care team and who are some of our partners on a care team to serve individuals. I think it's great that they've been, you know, students have been exposed to some other great Michigan organizations that we have here, like the Michigan Community Health Worker Alliance, the Rural Health Network, the Michigan Primary Care Association, and of course, NASW-Michigan. And, you know, it's great for all of you to share your experience and some of the challenges that we face as trying to get our services really adequately funded to be part of this future of healthcare, which is integrated health. Thank you. I'm going to stop the recording now, but I'm clapping, and I know that the students are clapping, but we're in virtual, so you can't hear it. So thank you again. I really appreciate it.